Welcome back, friends, in your own teleconferencing program. If you are a medical student, today's program is specially meant for you. This is the second session of our today's program, and the topic of this session is refractory anemia. To tell us in detail about refractory anemia, we have with us in our studios Dr. Haraprasad Pati, who is a professor in Department of Hematology, All India Institute of Medical Sciences. If you want to ask any queries about refractory anemia, you can use our phone numbers. The numbers are 29532844 and 29532845. Kindly affix 011 if you are calling from outside Delhi. And we have one toll-free number also, that is 1800112345. If you want to avail the DVDs of teleconferencing programs, you can contact National Board of Examination, and to download the forms, you can visit our website, that is www.natboard.edu.in. That is www.natboard.edu.in. So I come to you, Dr. Haraprasad Pati, and please kindly start about the refractory anemia and tell our listeners, tell our viewers about this particular topic.
Thank you. Refractory anemia, when you are talking about refractory anemia, means the refractory type of anemia. Anemia we understand, that is reduced hemoglobin or reduced the packed cell volume or hematocrit. So the refractory is to what? That will be refractory to the basic treatments. Usually commonly what you get is the nutritional anemia. That is the major chunk. About maybe 95% of anemias are due to anemia are due to the deficiency of nutritional causes. So when you really, the anemia which will not respond to the routine treatments, and most of them really respond to only the transfusions. So those are really category of refractory anemia. And it means that the other primary causes of anemias, whether the refractory, whether it is nutritional anemia or the other common hemolytic anemias, so or maybe marrow failure syndromes, all that when you have excluded, so then what remains is a small group of refractory anemia, because no primary cause is identifiable. So next definition, there is a chronic state. So it is not an acute problem, because it is refractory. So whatever you do, it will not come back to the normal. So the hemoglobin remains low. The anemia, so anemia is a chronic state. When you talk of refractory anemia, it is a chronic state of the anemia. So as I said, the most important fact is to exclude the other causes. The causes which a cause can be identified. So that's an enormous job. One has to, as a hematologist, your job is to exclude the other related conditions which may be related to the hemopoietic system or may not be hemopoietic system, may be secondary. So that has to be excluded, and that what remains will be the refractory anemia. Refractory anemia is synonymous with myelodysplastic syndrome. This terminology everybody is aware of. It's a group of disorder with a variable degree of sustained unexplained cytopenia, and by definition of the cytopenia is the hemoglobin less than 11 gram per deciliter. The ANC is the absolute neutrophil count be 1500 per cubic millimeter, and platelet count less than 1 lakh per cubic millimeter. But as I said, the diagnosis of MDS is again by exclusion. So diagnosis of exclusion of, as I said, the hemopoietic or non-hemopoietic disorders as primary reason for the anemia or cytopenia. And this is very important and critical. That's why one has to search for a cause. So what are but exclude other than these causes of the refractory anemia or due to MDS, there can be many other conditions which can be considered also as refractory. We can think of conditions, because in practical day-to-day practice one has to really think of these conditions, because MDS as a category is a rare category. So one should keep that to the end, to the last diagnosis. Can you name some of them which are hypochromic anemias and also refractory. Like look at the commonly, which this is common practice, like iron deficiency anemia. It may be a partially refractory. Like for example, if there is an beta thalassemia trait or alpha thalassemia trait is associated with an iron deficiency anemia, however, how much iron you may give, but however the hemoglobin will not be come back to the normal, because they are associated with a beta thalassemia trait or an alpha thalassemia trait. So this is one can be considered as a partially refractory hypochromic anemia. Like an iron deficiency, suppose associated with an inflammatory condition like a rheumatoid arthritis, again same thing will happen. The refractory will be a partial refractory to treatment. Of course, the others can be a relative refractory anemia. Like for example, if I am treating an iron deficiency anemia not with adequate dose, it will appear like an refractory anemia, or the dose or the treatment duration should be optimal. If that is not given, again it will not respond fully, the hemoglobin will not come back to the normal level. So those are conditions in a day-to-day practice one should keep in mind. The blood loss, this is a common cause of the iron deficiency anemia, is due to loss of blood in particularly the GI tract. The common ones we know that the peptic ulcer or the hook worm parasite or the piles. But many other conditions are there which need to be investigated by the endoscopic investigations. That the simple routine tests will not diagnose them. So they are the conditions one should keep in mind, like the hiatus hernia, the GI gastrointestinal polyps, or even the telangiectasis in the intestine. So these are the conditions which will not be easy to diagnose unless one specifically investigate to exclude those conditions as cause of the blood loss and causing iron deficiency anemia. Because simply by replacing with iron, those patients, the anemia will not be recovered and they will remain resistant to appear as if resistant to iron therapy. There are also other conditions which there is iron deficiency anemia, but they will not respond. Again, they are related to the gastrointestinal causes. These are like the H. pylori infection. These are 68% of H patients with H. pylori infection are found to have associated with iron deficiency anemia. The other condition is autoimmune gastritis. They are of course rare conditions, but one should keep them in mind and then only exclude. Otherwise, one should think they are refractory. The celiac disease, it can be even occult celiac disease. It may not be overt disease, but that can again present with an iron deficiency anemia without a cause. Like coming to little more detail about the H. pylori infection causing the chronic gastritis, it's if you go according to the refractory iron deficiency anemia group, then this will correspond to about 18% of patients of refractory iron deficiency anemia due to H. pylori chronic gastritis. How this H. pylori infection causes the iron deficiency anemia. This is through the mechanism of the achlorohydria, which causes reduced iron absorption, and though there is no bleeding lesions, if we do occult blood will be negative. However, if we demonstrate the H. pylori infection, they can be a cause of the refractory iron deficiency anemia. There are Indian studies also available on this, where it is found that if these patients are treated with iron replacement and also the antibiotics which are specific for anti-pylori infection, they do respond better, because simply giving iron, those patients will not respond and will remain refractory. And of course, if we do the endoscopic mucosal studies, you will find their gastritis, need not be the pan gastritis, it may be specific to localized whether in antral area or in other parts of the stomach. The autoimmune gastritis, again a rare condition, and but can cause a refractory anemia. Unless we keep it in mind and investigate, we may miss. A cause of refractory anemia, iron deficiency anemia in 20 is by autoimmune gastritis in 20 to 27% of patients, and this is more common, 4 to 6 times more common than celiac disease. If the three conditions, as I said, you will keep that in mind. The celiac, the autoimmune gastritis is one of the commoner compared to the celiac disease one. And this autoimmune gastritis has the tendency to progress to a full-blown pernicious anemia, and also there is increased prevalence of thyroid disease. The investigation wise, you have to do the serum gastrin level and antiparietal antibody, they can be demonstrated in patients. And of course, the autoimmune gastritis, because H. pylori also producing the chronic gastritis, so therefore one has to investigate and find that the gastritis is autoimmune, not due to the H. pylori. The celiac disease, it is a gluten sensitive stew which damages the small intestine, which interferes in the absorption of iron as well as the other nutrients including B12. And also the mechanism of the anemia is different mechanisms are there, partly due to blood loss, partly, as I said, the intestinal mucosal damage, so there is absorption defect, and they also partly due to the anemia of chronic disorder, because it is an inflammatory condition, it can produce also the anemia of chronic disease. So three mechanisms of the same anemia. This in Indian study is there from where it shows that 11 of the 55% of celiac disease patients presents with refractory anemia, and if you give them gluten-free diet, there is improvement in the hematologic parameters. Sideroblastic anemia, again this can be a multiple causes. One is the X-linked hereditary etiology, even drugs like the anti-tubercular drugs, the alcoholism, even lead poisoning, they all of them can cause sideroblastic anemia, and this is again one of the hypochromic refractory anemia group. Of course, the other two categories can be included here is the MDS RARS or the refractory anemia with ring sideroblast, MDS RCMDRS, which I will come to in detail little later. The refractory macrocytic anemia. All the megaloblastic anemias are not due to the B12 or folate deficiency, so some of them will not respond to adequate B12 therapy. So those are the ones can considered as refractory macrocytic anemia and need further investigation, like the malabsorption syndrome, the pernicious anemia. Of course, the other ones like then the MDS category, the refractory anemia, the MDS category, the 5q minor syndrome, which usually is a macrocytic anemia. So these will again I will come a little later. We'll coming to the refractory anemia as its disease entity is specifically called the MDS or the myelodysplastic syndrome. They are called the true refractory anemias, and the diagnosis, which I have already in the definition, as I said, there is a variable degree of sustained and unexplained anemia or cytopenia. So the important part is a sustained. It is a chronic, continuous anemia not responding to any therapeutic intervention. Second, unexplained, because you have excluded any other known cause associated with a anemia or cytopenia. And when you are talking of the cytopenia definition, the hemoglobin less than 11 grams, the ANC less than 1500 per cubic millimeter, and platelet count less than 1 lakh. In the classification of MDS, there was one classification called the FAB, French, American, British classification of 1982. It has the 5 categories: the refractory anemia with ring sideroblast, refractory anemia with excess blast RAEB, then RAB in transformation RABT, and chronic myelomonocytic leukemia. But this classification has lots of limitations because it didn't have any prognostic role by subclassifying MDS through the FAB classification. What the RAEBT or the in transformation we considered as more than 20 to 30% blasts, they really behave and need treatment like an acute leukemia. The other one is the 5th category, is the chronic myelomonocytic leukemia, CMML, is very different and behave like a myeloproliferative disease, so it need not be in the MDS category. Because of these limitations, there is another classification, newer classification in 2001, it is the WHO classification. There we have 8 subclassifications instead of 5. Here there are 8 groups. What are they? The 2 terms are retained. One is the refractory anemia RA and refractory anemia with ring sideroblast RARS. The new terminology added is refractory cytopenia with multilineage dysplasia RCMD. Another is RCMD-RS, RCMD with ring sideroblast. Another is the 5q minor syndrome. The RAB is divided into 2 groups here, subgroups. One is RAB1 and RAB2. Then the MDS unclassified, because even if you have so many subclassifications, still there will be some group of patients which you are not able to classify into any of the subcategories, and there you are putting them into the unclassified group. What is the advantage? And also there may be some limitation for this even with this WHO classification, because this WHO classification is applying the cytogenetics, and with cytogenetics we find that it is correspond to the prognosis, better with the prognosis. So prognostication of this group of MDS patients is better when you are including the cytogenetics in this WHO classification. The 5q minor syndrome is entirely diagnosis based on the cytogenetics is the demonstrating there is a 5q minus. If we are coming to the limitations of WHO classification, it doesn't classify the pediatric MDS. It is what we are talking of, the FAB classification or the WHO classification, both of them really talk about the MDS in adults. But we are also concerned about the pediatric MDS. MDS does occur, though of course rare, in the pediatric group as well. So this MDS in children, in adolescent, they are not similar to what you see in adults, because presumably the age is so different, so the categories occurring there are also different. The categories in the WHO classification, what you call the RARS, the RCMD, the 5q minor syndrome, are just rare or non-existent. In contrast, the 20% cutoff which you have applied in diagnosis of acute leukemia and separating from the MDS category, in the 20% cutoff again we are taking in the category of RAB2, is found that in children it makes no difference, because even up to the RABT which was previously there in the FAB classification need to be retained when you are classifying the MDS in the pediatric and the adolescent subgroup. In the MDS, so in the children and adolescent, if you want to subclassify, we can really subclassify into a limited number of subgroups. We can put only 3 primary MDS as into 3 subcategories, that is the refractory cytopenia with less than 5% blast in the bone marrow, and RAEB is the 5 to 90% of the bone marrow blast. This is equivalent to the RAEB 1 and 2 in the adult. Here it is just put in the 1 category. And RAEB T, which was there in the FAB classification, need to be retained if we are classifying the MDS in children and the adolescent subgroup. And the fourth one is the secondary MDS. In children, there are many disorders where you are giving a chemotherapy or there is radiotherapy. So many of them do present with a secondary MDS. In also children, there are several marrow failure disorders which start in the early age of life. So the congenital bone marrow failure disorders. One can find the secondary MDS in this group of disorders, and those are again put in the secondary MDS category. Aplastic anemia. If it is a prior aplastic anemia and then there is secondary MDS occurring in those patients, that's called again considered as a secondary MDS. The diagnosis of MDS, it's difficult because or a genetic marker. Many of the leukemias like chronic myeloid leukemia or myeloproliferative disorders nowadays, there are specific single cytogenetic abnormalities, genetic abnormalities are identified, which is nothing like that in MDS category. Even if there is some recurrent cytogenetic abnormalities are detectable in myelodysplastic syndrome, but the overall you do not find these abnormalities in more than 50% of patients. And if you subcategorize, then in subcategories like refractory anemia or the refractory anemia with or refractory anemia with ring sideroblast, in these categories the cytogenetic abnormality even much less. So the most important diagnosis comes from the peripheral smear examination, the bone marrow aspirate morphology. So that remains the most important diagnostic tool. So then is that there must be some minimum diagnostic criteria to diagnose a myelodysplastic syndrome. So what are they? One, as I said earlier, there should be unexplained and sustained cytopenia, or maybe just cytopenia maybe in one cell line, just anemia or thrombocytopenia or leukopenia or a different combinations, bicytopenia or pancytopenia or monocytopenia, and that should be more than 6 months duration. And second important one is that exclusion of all other hemopoietic and non-hemopoietic disorders as primary reason for this cytopenia. That has to be excluded. And next, along with this, either you find the number of blasts in the bone marrow are either more than 5%, or you demonstrate the dysplasia of more than 10% cells in one cell line. Like if you are looking at the erythroid, dysplasia is there, it should be present in more than 10% of the bone marrow erythroid component. Or if you are looking at the macrocytes, then macrocytic dysplasia should be present in more than 10% of the macrocyte cells. Or if you are looking at the granulocytic cells, again more than 10% of the granulocytic cell should show the dysplasia. Just seeing finding few dysplastic cells here and there, that doesn't really give a criteria for the diagnosis. Or the next alternative, is that you can demonstrate the typical chromosomal abnormality, like whether it is 5q minus or the monosomy 7 or trisomy 8. So any of them, these one like this type of chromosomal abnormalities, you demonstrate also. So these two together will is taken as the minimum criteria for diagnosis of MDS. We have also subclassified the MDS in the pediatrics. So there should be some minimal criteria for diagnosis. As I said, the MDS is different from the MDS in adults. So there are therefore the subgroups needing for a minimal diagnostic criteria a little different. So here it is taken as at least 2 of the following 3 criteria as taken as diagnosis. 1 out of these 4, out of any 2 will be make a diagnosis. Unexplained sustained cytopenia with more than 5% blast count, dysplasia of more than 10% cells, not in one cell line as in adult MDS, but in 2 cell, at least 2 cell lines. So that has to be there. Or there is clonal cytogenetics as we have found in MDS in adults. So these two of these 4 criteria are important to make a diagnostic criteria. So we are looking at the bone marrow tissue erythropoiesis. It's an important observation because whether it is looking at the percentage of blasts, that increased number of blasts more than 5%, or it is the dysplasia of the marrow, so that will come from the bone marrow morphology. So what are the features of dysplasia? The dysplasia will include the peripheral blood. You can demonstrate the Howell-Jolly bodies, the basophilic stippling, the presence of red cell changes like macrocyte, teardrop cells, dimorphic red cells, and bone marrow the erythroid precursors. You can demonstrate the internuclear bridge, the nuclear budding, the karyotexis, that is the nuclear fragmentation, the budding. The brief budding means the nucleus, the unequal division of the nucleus will be there, or there may be a megaloblastic maturation of the erythroid component in the bone marrow, which do not respond to the B12 folates, or there is a maturation arrest. Normally you will expect the erythroid component with have a orderly maturation from the pro-erythroblast to intermediate erythroblast to the late erythroblasts, whereas here there will be maturation arrest. There may be at any stage the further maturation is not occurring. Or when talking of the megaloblastic maturation, it need not be really all cells are showing the megaloblastic maturation. It may be asynchronous. In some of the cells will be showing megaloblastic maturation, others may showing really a normoblastic maturation. So that's a mixed pattern what you may find in as a dyserythropoiesis. What about dysgranulopoiesis? Which cells will be dysgranulopoietic at identifying features? If you look at the peripheral smear, you may find there is abnormal granulations in the cytoplasm with focal granules or the hypogranulation, or there may be large few granules. So those are also equally important. The pseudo-Pelger anomaly, the nuclear hyposegmentation of the neutrophils, you can also demonstrate that as a feature of a dysgranulopoiesis. Ring-formed nucleus, divided 2 separate nuclei in the same cell, the megaloblastic maturation, nucleolated myelocytes, looking like or called the monocytoid the myelocytes. So these are also again features of dysgranulopoiesis. Dysmacrocytic, you can find the platelets showing the giant platelets, or the abnormal granulation or the agranular